This conference will now be recorded.
Good morning, ladies and gentlemen, and welcome to this online CapsoCam Plus training session. I hope you can all hear me clearly. I'm Srini Muthuswamy from CapsoVision. I'm indeed honored to introduce once again our global key opinion leader and CapsoCam Plus expert, Dr. Tomasom Pachofsky from Vena. Dr. Pachofsky is associated with CapsoCam Plus from 2012 and has completed close to 900 capsules, CapsoCam Plus capsules so far. He has also immense experience with PillCam SB3 and MyroCam and can share thoughts about and questions about all the capsule systems that's available right now. Over the next 90 minutes, Dr. Pachofsky will go over how to effectively diagnose with CapsoCam Plus. We are recording this session and this will be made available to you after the presentation, so you can share it with your friends and colleagues and could be a good reference. Please mute your lines if you're not talking. We will be happy to answer any questions. You can either type the questions on the chat, or you can also ask them at the end of the session where you will have a time. So that said, Dr. Pachofsky, over to you.
Thank you for the introduction, Mr. Srini, and welcome to all to this first online course this year from me. I will give you a short introduction about the product, and then we go on with the software. I will show you how to work with it, how to use it. It's a quite intuitive software, so you will see it's really easy to learn how to handle it, and I will show you what you can do with this. But first, we will start with a short presentation and an overview of the system. So as Srini told you, I'm not only working with the CapsoCam. I started in 2003 with the PillCam. In these days, it was called M2A now we have the fourth generation of the PillCam SB3, and we're working with this system, also with the MyroCam, the new double-headed capsule, and the preferred system in my unit is the CapsoCam, and I will show you why we use it as preferred system. So what are the features of the capsule, the CapsoCam Plus? We have a size of 11 by 31 millimeter. We have a 360-degree panoramic view because of 4 cameras. We have a resolution of more than 220,000 pixels, a smart motion sense, which means if the capsule goes down faster, the frame rate will go up to 20 frames per second. So the chance to miss a lesion is really good reduced with this frame rate. We have an auto illumination with 16 LEDs. We have a recording time of 20 hours. A wire-free technology, so there are no cables needed, no data recorders, all is saved on board. There's built in a 1 gigabyte storage, and we have a data transfer and optical interface. So what we are working with is the CapsoCam Plus, the third generation of the CapsoCam. We are working with the CapsoAccess, with the infrared device to transfer the data to the computer. And we have a quite good intuitive software. And as you can see on this picture, this is the only software you can use on Mac. So you're totally free. You have a Mac version, you have a Windows version, so you can work with every computer you want to work with. Because of the onboard storage, we need to get the capsule back. So we need the capsule retrieve system with the pan. The pan is fitting to every toilet. You get a magnetic wand, so you can catch the capsule totally contact-free, and you get a small vial where you will put in the cleaned capsule, and that's what you will get back. You get the capsule in the vial, and then you can transfer the data to your computer. The Capsule Access, I told you, the optical interface. We have a sensational download time of 12 to 15 minutes. For all of you who are using the Medtronic SB3, you know you have a download time up to 90 minutes, or for a Crohn's capsule, maybe more time, up to 2 hours. So that's the absolute fastest download of all systems. Another good thing is during the download, you can work with the computer, you can look at other examinations, so you can open different windows of the software and work parallel with it. So why do I use a lot of CapsoCam Plus? It's because of the 360-degree field of view. It's quite the largest field of view you can get with capsule endoscopy, and I'm sure we will find more pathologies. And I will show you why I'm sure, because the only landmark in the small bowel is the papilla fateri. And there are several studies about detection with an end view system up between 10 or 18%. There's a really small examination of only 10 cases with a detection rate with a double-headed PillCam colon of 60%. And the first published study from Germany showed with the 360-degree lateral viewing a detection of 71%. And I will show you a short case, and you can see really good the papilla. She's spitting a little bile. And in our series of more than, in this data, we have included 852 cases. We had a percentage of 81.7%. As Rini told you, now we are at the number of more than 900 at the moment. But these are the data from the end of 2018. Another advantage is it's easy to handle for patients and professionals. So just take a capsule, swallow it, and it will work. You don't have to do any long administration before you can start. Just take the capsule and it's going on. You have no interference with other implanted devices or even with handy computers, WLAN, whatever you want, because there's no emission of the capsule. All the data are stored on board. And it's the best comfort for the patient because you don't need a sensor belt. You don't need a data recorder. No one will see that there's an examination ongoing in the patient with the CapsoCam. It's also a kind of patient safety because we need the capsule back, as I told you, so every patient knows exactly that the capsule is excreted. You know it from the other systems with data recorders. There are often some patients who are coming in telling you, I can't find the capsule in the stool, I'm not sure she's out. So you have performed an X-ray to say, yes, it's still out. With this system, you're 100% if you get the capsule back. And you're totally independent. You can do 20, 50 capsules a day if you want, because you don't need any more equipment to start the examination. Every new system will get some fear, and I will show you some fears of colleagues. Data loss because of lost capsules. Yes, it's true. If the capsule is lost, we don't have any data. But in our series, and these are the updated data from 2012 to 2018, so 7 years experience with the CapsoCam, and only 21 patients of 852 have lost their capsules. So this means 2.5%. Data lose, or I will say delay, because of retention. It's also true. If the capsule won't come out, we don't have any data. If you work with a data recorder based system, you can say what's going on inside, but we can't do it with this storage on board. With the CapsoCam, she's a little bit longer than the other capsules. We have only 4 times a retention in the jejunum. The longest patient over 6 months. One of this 6-month lady were a Crohn's disease, and all of them are solved by enteroscopy. So we have a percentage of retention of 0.5%. Another fear are stool contaminated capsules. And I can guarantee you, you will get back the capsule totally clean. The patients will be ashamed if they bring you back a capsule with stool. You get it clean. Patient acceptance also really good. When we started, I've been not convinced what will the patient say, because they have to bring back the capsule, they have to search for it in the stool. But it's really, really good. When we started, I let them choose data recorder or bring back the capsule, and most of them told me, please give me the system. I have no data recorder and I will be free over the day. And another fear is the quality of images. And I will show you a comparison of the leader on the market, the PillCam SB3. All of you know these brilliant pictures, and you see also an examination of the CapsoCam Plus. And I think you will agree that we have the same quality, we can see the same details. There's no difference in the quality of the images and what you can find with this. So to the procedure, I will tell you how we do the procedure in my unit. We tell the patient that they are allowed to eat the last meal at 5 p.m. the day before the examination. They came to us to the hospital at 8 a.m. Then they get 1 liter pack solution. It's because we want more fluid inside. You know, it's better an underwater image. You can see more details with this. So they drink this 1 liter. After drinking, they are swallowing the capsule, and then we allow them to drink water for the next 4 hours. After 4 hours, they are also allowed to eat whatever they want. And after excretion, they bring the capsule back to the hospital, and we can download the data and create the report. So it's quite simple, it's quite easy. We have a really good acceptance of the patient. Many other centers in Austria are using 2 or 3 liter pack solutions. I think it's a little bit hard for the patient to prepare like for a colonoscopy. So we try to make it easy and quite well for our patients. Then I will show you the most common findings. We will also see after this introduction in the cases. I've prepared 10 cases for you. We will see how much time we have to show most of them. The most common finding are angular dysplasia in 50%. Then ulcers, most of them because of NSAIDs. There can also be an ulcer de la foie. Neoplasia, up to 9%. You know, before we had the possibility to perform a capsule endoscopy, we don't know how high the number of neoplasias in the small bowel is, and now we can find really a high number, up to 9%. Then also in 7%, fresh blood without a bleeding source. If we have an ongoing bleeding, you can see only red. You can't detect, or often you can't detect the bleeding source, but we can then say, okay, there's an ongoing bleeding in the small bowel, and then think about the solution of this problem. Then Crohn's disease, even also up to 5%. You can see these ulcers and this big fat villi with inflammation around. And then some smaller numbers of Meckel's diverticulum, enteritis, diverticulitis, what we can find with the capsule endoscopy. So how we are using the CapsoCam. As I told you, we started in 2012 with a really small number. It was the first contact with the CapsoCam. We are showing how it is working. The first generation, we had to cut off the head of the capsule to download the data. So we had a small number of 19. And over the years, you can see we're going up and going up. And last year, we had a percentage of using of 65%. It's because we see that we have better results, we have more positive findings, and we have a lower number of examinations with no pathology. So that's why we are using the CapsoCam in more than 65%. We've now done overall, since I'm started with the capsule endoscopy, more than 3,000 examinations. We've done till the end of last year 852 CapsoCams, and out of this 560 CapsoCam Plus, and at the moment we have a number a little bit over 900. So our data, only 21 patients lost their capsule, meaning 2.5%. We had 3 capsules with 1 defect camera. It's only the first generation. We had 15 download problems with the second generation, and here we have a data loss in 5 capsules. So totally we have 26 capsules with a data loss. And at the moment we have no technical problems with the CapsoCam Plus. We have 4 times retention in the jejunum, I told you before. We have a fantastic colon reach rate of 97.4%, and there is a fault. If you look here, the examination time now is already up to 20 hours, not more the 16 hours it was the sometimes before, but now we have 20 hours. That's the causing of the colon reach rate of 97.4%. We have an excellent reading time of 15 to 20 minutes with the dual mode. I will show you after this introduction in the case series. So we have a total loss of data of 3.1%, and we are looking what's going on with the data loss in the end view capsules in the same period because of failures with the SD card in the data recorder, with data recorders, failure of the capsule, or with the sensor belt. And in this period, we have a data loss of 6% in the same time. So what are the improvement of the CapsoCam since we've began 2012? It's the image quality. We have now the 3rd generation of the CapsoCam, and we've got it within 3 years. With the given or now Medtronic system, we have 4 generations, but till the last generation we need 10 years. We have the fastest download of all the capsule systems within 12 to 15 minutes. We have the reading software, the CapsoView. You will see it in 1 minute. The dual mode I told you. You can adjust the contrast and the color. We have an advanced color enhancement system. You can open multiple windows, even you're downloading a case. We have the examination time with the CapsoCam Plus up to 20 hours. And it's the only capsule software you can use on Mac. An excellent reading time of 15 to 20 minutes because of the intuitive software. And we have a great service of the company. So even there is a problem, it will be solved in a really short period. So that's my thoughts of the system. And now we will go on with the software. And here I have opened the first case. When you look at it, you will see it's looking like the other softwares. You know, you have a button to go forward, you have another one to go backward, and you can go step by step. If you're using a mouse, you can scroll and you can go on or back, even as you like. You can here change to the dual mode, the panoramic or the stack mode. I will show you after the first case. You can go on with the speed. I think for this day we will go on quite easy with only one time. We have here the sharpness. You can do it like you like it, how it's good for your eyes. We have the color bar where you can change the color, also more red or less red. So we will go on with this. Then we have some presets. It's nearby like a FICE or an iScan or a little bit like MBI. It's not at the moment that you can use it every time and you have a very big benefit, but in some cases it's good to have it. We have here a color bar, and if you look at it, you will see I've done some marks before. The blue mark is for the stomach. The yellow mark is for the small bowel, and here at the end, the green mark is for the cecum or for the colon. And if you look at this, often you can see there's a skipping in the color, and in this area we can suspect that there maybe will be the change from stomach to the small bowel or from the small bowel to the colon. If you look here now in this area, I hope you can see that it's looking a little bit red. And we have here built in a red detection, and if we will activate it, you can see we get so small columns, and every one of this means a picture here. So we have a lot of red in this. So we have an ongoing bleeding, and before we start with the examination, you can see with this item, okay, there's an ongoing bleeding. We know where it will start, and we can say, okay, we look here first, what's going on. So, but I will close it. If you wanna make a picture, a thumbnail, you can click here, and we will get a thumbnail here in this area. If you find something you want to mark, we can do it like this, or we can also do an ellipse. There's a magnification built in, so you can see here the mucosa a little bit better. Sometimes it can help a little bit. Here you can change to the full screen mode or go back if you want to see the thumbnails you have made at all. This is now a de-identified video, but here you will see the name, the patient ID, who's the referring physician, the capsule ID, and the capsule runtime. And if you're still ready, you can also create the report here inside of this software. So it's a all-in-one package, and at the end it will create a PDF file. You can look at it in every browser, and you can export this report. So how I'm going on with a new capsule, I will show you. First, when I start, I do it every time the same. I click here in the bar and go on quite slowly, because with this often I can see a lot of pathologies within some minutes. And even it's good if the red detection is not so perfect. You can also see if there's an ongoing bleeding. It's the main indication for the capsule endoscopy. So then you know, okay, we have to go on with the reporting to see where is the bleeding source and how to solve this problem. Do we need a surgeon or an X-ray or an enteroscopy and plan it as far as possible? So now we are in the region of the red detection. You can see there's a lot of blood, and that's it for the first time. Here in the column you can see it's quite black. It's the melena of the ongoing bleeding. So then we go on with the first step. We are searching for the first picture of the stomach. So I will start here at the beginning of the video. We have here some pictures of the esophagus, and if we are going back, here we're still in the esophagus, but here I think we can be sure that this is the first picture of the stomach. So it's still marked, but if we are going here to our camera, it will tell us to give a thumbnail to this landmark. I will show it to you on the next video. So that's the first picture of the stomach. Then I go here, press the mouse button, and then I go in this area where there's the color change. And here I will start again to look at the video. So we are near the pylorus. And if you look at this picture, I think all of you will be with me when I tell you this is the small bowel. And here now I'm going back some pictures. Here we have the stomach. Here we have anything I can't tell you because we are so near to the mucosa. So I think it will be the pylorus, so we can only see the flashlight. And here in the next one, the next picture, we can see villi, so we have to be in the small bowel, and we can do the next picture and set a landmark to the first picture of the duodenum. And then we do the same again for the CCAM. So we go near to the CCAM. Maybe we are too far, then we are going back. Here I'm sure we are still in the small bowel. With this system, sometimes it's a little bit hard to say if we are really sure in the CCAM because of the lateral viewing. You will often see a little bit of colon mucosa here in this area, and you will also see some mucosa of the small bowel. So we have both here, and sometimes it's not so easy to say it. So we're going on a little bit forward. I'm sure here we still have small bowel mucosa, but this here is the colon, the CCAM. So we will mark it again. You can see it's still marked, and that's what we have to do in the first step. So now we have our landmarks. You can see blue for the stomach, yellow for the small bowel, and green for the colon. And then we will go to the first picture of the small bowel, and then we can start here with the examination and with reporting. Yeah. I told you we have a quite high number of visibility of the papilla fata. We can see some bile here in this area. So we will be near. I'm not sure if we will find it here now, and I won't spend too much time here in this area because we have not so much time, and I have a lot of good cases for you. So that's the principal start of every examination, where you can get on with it. You will see there's no big problem. So because I know this case, we will go down to this area where the bleeding will start. And you can see, as I told you before, in 7% we have a bleeding source you can't identify because of the bleeding. Sometimes we can think maybe here is an active bleeding source or in this area, but I also can tell you in this case we won't find it. But this case was only to demonstrate how the software is working and what you can do with it. I will show you some other features in the next videos. And then I will say we will go on with the second one. So you can start a video here in this area with opening video, or I will close it. If you get on totally new with the software, you can start it. Then you can also get here to go on with the first video. So I will take the number 2, and I'm astonished because, but I will give it away, my marks, so we can start from the beginning, and I think it will be quite better without the marks. So now we have all of them gone, and we have here nothing we can see. So in this case, we will start the same way than before. First, I click here inside and I'm going down. You can see here in this area in the stomach, there are some red spots. We will look at them later on. Then you can also see here, we have here a change in the color. So we're looking what's going on in this area. And you can see really there is the change from the stomach to the small bowel. And if you look at this here, only with this very quick view, you can see here is an angiodysplasia. So we can set the mark here in this area, and then you're going on, and you can see also here another one. So even with this method, you can find a lot of pathologies in your examination. So if you look here, it's not so easy to say even there is really a change in the color bar. So I'm not sure where it is, but I'm sure that we are here in this area. We are in the colon. So we have a complete examination. Yes, we're in the colon. So, and then we can start with this, and we are going on from the beginning. So what I forgot to tell you, we have here also the possibility to mark the first esophageal mark. So we will do it. It's then in orange. And we are going down till there's a change. Here maybe we have some varices in the distal esophagus. And we are going down, and here we have the first picture of the stomach. And then I think we will go on here and go near to the color change in this area. And we try to identify the duodenum. You can see we're here near the pylorus. Now we're in the duodenum, here stomach, and the next picture is still in the duodenal bulb. So we set the next mark, duodenal, and then we have the problem that we can't see here good and quick where the change to the CapsoCam is. So we have to go on a little bit slowly. So often it's the change if you can see a lot of stool here. So I try to go back. So now we can rise a little bit. So, and now we are inside of the ileum. We go on forward. And I think it's not so easy to say, but here we have also this flashlight, so it will be very narrow. And if you're going out here, just going back a little bit, here, the narrow thing, then a lot of stool here in this area, still the mucosa of the ileum. And then here in this area, I'm sure we have the mucosa of the cecum. So we set our last mark, the cecal mark. And if we switch here, you can see the thumbnails, the first esophageal, gastric, duodenal, and at the end, a cecal landmark. So then I will show you this dual mode. The advantage of this dual mode is you have two of these picture bars. And if we're going on, so you can go on with, if we go to the lowest fastness, we can go on here, and you can reduce extremely your examination time because you see two pictures at the same moment. And I think you have seen the same like me. So we will start again here, because we have here our first really big angiodysplasia, so a potential bleeding source. And even here another one. And now it's the same like with other capsule systems. We have to go on and to mark all the lesions. I think for now I will go back to the panoramic view, because it's much easier for you to look with this view. I think it will be hard enough to look at a CapsoCam study, even you don't have seen a CapsoCam at the moment. But I will also show you the stack mode. In the stack mode, you will remember from the other capsule softwares that we have this also a stack mode where you have 4 pictures, but here we have camera number 1, 2, 3, and 4. It's a mode I don't like it. I can't do it like this, but I also don't use it for a Myrocam or an SP3. So we will work today with this mode, and here we can go on, and you might have seen that I've missed a lesion, but there are so a big number. We've had this before. We have here another small one. We can click here, and we have really a big number. Another one, we can mark it for the colleagues so they can identify it also for non-gastroenterologists. Here you've seen another one in this area. I showed you, you can do it like this, or even you wanna do an arrow so everyone can identify it. But I will show you another feature of the software, and I will go to this big angiodysplasia. If you are not sure what this should be because you're totally new on capsule endoscopy, so we have built in a library. And I hope it will work. The moment that the power of my computer is a little bit reduced because of the online training. But here we can look for the small bowel. We can go for diagnose, and we will look here for vascular lesions. And then you can say here a lot of number of lesions, here called vascular ectasia, AVM, or like I call it an angiodysplasia. That's how it's looking. You can make it bigger, and you have here the comparison, what's going on. So you have a help built in the software to find your pathologies and to name your pathologies. So here another one. We will make a mark. And that's a patient with a severe iron deficiency anemia. And he had an Osler disease. As you can see, really a big number of those angioectasia or angiodysplasia, as you like to name it. So I think we will go on with the next case, because all of you will know these lesions, and I think it's the easiest thing to find them. And in this case, we will find more than 50 of this angioectasia as bleeding source. So I will show you another case. I will go on with this. So even the same procedure, click inside of the bar and go down quite slowly. You can see we have here the small bowel. There was a change. If you look at this, you can see a lot of funny stuff here inside. We will look at it then if we look at the whole video. So you can see again with this here, with this method, you can find the main pathologies within some seconds or minutes. So I'm going on. Even it's necessary to know if we have a complete examination. And here, I'm sure we are in the colon. So we go on with the first picture. And we will start. I will do the same procedure than before. We will searching for the first picture in the stomach. I will mark now the esophagus. So here maybe, but you can see it's quite black. We have here one thing, but here we can say yes, we are sure this is a gastric picture. From the color change here in this area, I'm not sure. So I click inside the bar and go on slightly. We're still in the stomach. Here I'm sure we are in the small bowel, so I'm going back. Here we're in the stomach again. And that's, I'm sure, the first picture of the duodenal mucosa. And then we have here in this area a color change. So maybe in this area there will be the really change of small bowel to the colon. So we start here with a lot of bubbles in this case. And even if you look at this picture, this is an older case. It was from the 2nd generation. You have here a lot of pixelations. You won't have it now with the CapsoCam Plus. So, and here I'm sure we are again in the CCam. So we have the first cecal picture. And then we will go on from the duodenum. In this area you can see this structure. You will see it quite often. You can see it here now clearly. One of the differences with the lateral viewing system is you can see on the left side the same than you can see on the right side. That's the pylorus from the duodenum. It's because we have not even a 90-degree angle of the 4 cameras. It's a little bit bigger. Here in the middle, the software will reduce it. You won't see a double sign, but on the side, here is camera number 1. Here starts number 2, number 3, and number 4. And there's an overlap of number 3 and 4 because you have to think that the pictures are wrapped up. So you get this banner, and so you can see on the left side what's also going on the right side. So that's the pylorus. And we will go on. And here you can see the papilla. You won't see it quite often with an end view capsule system. She's still spitting some bile. And then we're going on. And here is our first pathology. I'm just missed it. I'm going back a little bit. Here we have this. This is a submucosal mass. Here another one in this area. You can see it because there's a difference in the surface because of the volume under the mucosa. The mucosa is flattened, and you can see here how it's looking. And we go on, and I won't stop now for all the lesions because you can see here again a lot of submucosal masses. I can tell you all of them are lipomas. And as you have seen in the video, the lipomas start quite after the papilla fateri. So it was not seen in a routine gastroscopy. This was a patient with a severe iron deficiency anemia at all, never seen melena. And so we performed upper GI and lower GI endoscopy. Here again, a lot of lipomas in this area and without any pathology. So we done in the next step the capsule endoscopy, and we found distal the area we can reach with upper GI endoscopy, all of those lipomas. So we're going down here, but then we will find another process. All of them are the same. Here you can see or expect it's looking a little bit yellow. And then I will stop when we came to the area where the pictures are changing. But we will go on for 1 or 2 minutes, I think. Just look at the good quality of this video. Even I told you it's an older video. We have some interference here in this area. It's now solved this problem with the new software and the CapsoCam Plus. Maybe we will go down a little bit faster, so I go and double the fastness. Again, lipoma left, and the same on the right side. I think we are now near the area of the main pathology. Here also big lipoma in this area, and here if you look at this, it's looking a little bit different. It's also submucosal mass, but we don't have those flattened villi. If you look at this, again on the right side and the left, we have the same pictures, and that's totally another thing if you compare it with this. We have big fat villi, they have another color. So going on, I think I will reduce my speed so we can see the details better. So here's something's going on in this area, and we will follow this lesion. So I will go on here again, this lesion in the middle. If you look at this here, you can see another detail. Here it looks like an ulceration in this area. Also again on the left side. And we're going down a little bit. Here again. Here you can see another lesion on the lesion here in this area now. This is all a kind of ulceration and fibrinoid mucus on this lesion. And this is our bleeding source. This was an adenocarcinoma of the proximal jejunum. In the specimen of the surgery, it was 10 centimeters long, and it was nearby occluding the small bowel. but the capsule can passing through. You can see here the really big ulceration of this process here in this area, relative normal mucosa also in this area, and here the big ulceration. So we have here another picture, relative normal villi, here the big ulceration, and this is the bleeding source for this iron deficiency anemia in this patient. So really good visible, you can see how long the capsule is in this area. You get a lot of data of this tumor, and now we're passing through, and we have again distal of this lesion some lipomas in this area. In this case, I will stop and then we will go on with another case. We have also, I can't find it at the moment, but it doesn't matter. So we've seen a tumor at all, and we will go on with the next case. You can see I've prepared it at all. We have also a lot of lesions here in this area. So you know what we are doing. We're going down. And here again, you can see only with this method we can find some lesions. And we will try to find also the CCAM. Here a lot of lesions in this area. Here really big severe inflammation, but we are just searching for the CCAM. And here again you can see we have a complete examination, and in this case I have marked it at all. You can see we have here the green mark for the CCAM. So in this area we're still in the small bowel, and now we're going on to the CCAM, here the cecal mucosa. But we will start again here in this area. From the stomach, and you can see we have in this case also a lot of lesions in the stomach. If you look at these pictures, you can see fibrin, ulceration, also in the stomach. Here also a lesion, inflammation, and some blood in this area, more blood here in this area. So we can find some lesions in the stomach. There's a little bit a kind of bleeding in this area. If you look at this, there's some fresh blood at all. And we will start here now in the duodenum. Again, we are in the area of the papilla, but I won't search for it now at this moment because we don't have so much time. So we're going down. This was a young male person with loss of weight and diarrhea, and so you can imagine what we will find. They will going on a little bit because we have also a lot of lesions. You've seen it before. So we have different types of lesions. You can look at this here. It's a small aftoid lesions in this area. We're going on. We have some bigger lesions with inflammation around. Sometimes we can see this a little bit better with this preset. In this case, not really. And we are going on. Here also bigger lesion in this area. So we have some aftoid lesions, some ulcers, but we will go to the main thing, and I will show you here in the distal part, because there's now a dramatic change. What we can see, there are also some ulcers. Here a really big ulcer in this area, but it will become much better. And if you look in this area here, you can see really big fat villi, a lot of inflammation, some intramucosal bleeding as reaction of the inflammation, ulcerations everywhere, and that's a Crohn's disease, a young male patient with the first diagnosed Crohn's disease in the small bowel. Really impressive how big those villi are when you remember how small and good defined are they in the upper GI tract. Look at this, and I will give you another picture of the normal mucosa here in this area. I think it's quite impressive, and you can see how good you can imagine the details here, the normal mucosa, and here in this area, the severe inflammation. Also here we are distal, we are near the ileum or in the ileum, and here you can see it's looking nearby normal in this area. And if you're going up a little bit, so the typical lesions of a Crohn's disease. So, Mr. Srini, should we go on with another case, or do you have got some questions of the participants?
Yes, we are at 10:20, so 10 more minutes for the session to complete. We will be happy to take questions from any of the audience. Any questions you want us to answer, or can we move on to the next case? You can also type down your questions on the chat window so I can pass it on to Dr. Pachofszky.
Maybe I will go on with the next case.
Please.
Even there are some questions I will interrupt.
Yes.
But it's a quite short case. I will show you, because it's also a kind of bleeding, but it's a typical case. I think you can diagnose within 2 minutes, but I will find the right way. You can see there's some bleeding, and I will start here with the video, and here you can see those scalloping folds, the loss of the normal villis, and it's not so bad that we have also some bleeding, because then you have a better contrast and you can see quite better the structure of the mucosa, and this is the typical finding for celiac disease. We are in the upper jejunum, and you can see it's totally different to that mucosa we have seen in the cases before. We don't have any kind of inflammation, but we have this loss of villi and those scalloping folds for the celiac disease. And if we are going down, you can see that in this area we have also the blood, but here, if you look at this, we have a totally normal mucosa, as we will expect it for healthy people. So a normal mucosa in this area, in the lower jejunum, and here this pathological folds in the upper jejunum. So if we don't have any more questions, I will go on with the next video. I will show you another case. This was a lady, I think up to older than 70 years, I don't know now exactly at the moment, and she had some periods of gastrointestinal bleeding. I will show you this case with the dual mode so we can spare some time. And here you can see again a lesion in the jejunum, but I think we will find a better one here in this area. Not so good, but we have a lot of other lesions in this area, so I will go on with this and maybe I will show it to you. We have here also some smaller lesions here. We have a little bit bigger lesions in this area, and then we came in an area with really big ulcers, and here also a lot of inflammation in this area. But maybe you will think it's looking like the Crohn's disease of before, but this is an NSAID enteropathy. She had a problem with her knee, and she's swallowing a lot of NSAIDs, and that's what it looks like, an NSAID enteropathy. And all those lesions you can see are the cause of the gastrointestinal bleeding. So with capsule endoscopy, you can't say you can't name the disease only by the pictures. You have to know the history of the patient. You have to know some details. You only can say or describe what you're seeing. You can say we have some ulcers, some F2-8 lesions, we have inflammation, but you can't give a diagnosis because it can be looking like NSAID enteropathy, like a Crohn's disease. It could be a kind of vessel disease, like a morbus Bechet. A TBC in the small bowel can also look like this with a lot of ulcers. So we have some diagnosis, but we can't name it only with the capsule endoscopy, with the pictures and without any history of the patient. So then I will show you another
Dr.
one.
Pachofszky,
Yep.
there are a couple of questions. I think it's good time to answer those questions. So one of the question from Dr. Ali Madian, please could you clarify the orientation of arrangement of images on screen? I have difficulty in imagining the horizontal arrangement of images.
Yeah. If you imagine the capsule, we have 4 cameras around the capsule, and the software is wrapping up this, and we have here in this area, from here to the left, the first camera, then is arranged the picture of the second, then the third, and the last one. So if you take the left and the right end of this picture bar, and you try to close a circle, then you can imagine how the cameras are arranged around the capsule. And that's one of the difficulties at the beginning if you're looking at cases with the CapsoCam, because with all the other system, these EndView systems, we know how to look from birth on, because that's our imaging we know. And here you have to look what's going on. You have to think with every picture, but it needs some cases to understand it and to have the orientation where you are. 10 to 20 cases and you will be perfect, and you know how to work with this new imagination of the small bowel.
Thank you. The next question, this is from Laetitia Durant from France. I would like to know if Dr. Pachofszky uses the report template and how he uses it.
I can give you a short example. Yeah, you can here decide to include the pictures you found. Yeah, with this I can choose all my pictures. If I now start here, I can write down the clinical history. So I will say GI bleeding several times. Then I can give a description of my procedure. So I will describe where I find the lesions, how many lesions, how big they are. So find some ulcers. I will do it quite short, and then the finding summary. So I will say several ulcers and severe inflammation in the jejunum. And then you can also give some recommendations what to do. With the NSAID enteropathy, quite easy, stop NSAID. And then you can also enter a letterhead. Here now for my unit, I'm at the Krankenanstalt Rudolfstiftung in Vienna. This is the address, my email address, if there is anything to discuss, and my phone number. Then press OK. And here we can look at everything is quite slow at the moment. And here is now my report as PDF file. So that's how it's looking. The head of my department, my name. Here you get included all the relevant data of your patient. We have the clinical history, the patient data with the transfer time of the esophageal transit, small bowel transit, whatever you want, the description of the procedure, summaries, and the recommendation. And then you get all the pictures you've done inside. You can choose it, so you don't have to include all the findings. You can choose what you really want to go and want to take to the report. So we have here now a really big number and a lot of papers if we will print this. And then you can go to print, you can store wherever you want, and you have a complete report of this to finalize the examination.
There was a similar question on reporting by Dr. Walid Elkani from Egypt. Obviously, he's asking for many more sessions. And yes, we will offer more sessions, and also online training sessions will be recorded and sent to you, which will be form of training for you. And also, Dr. Pachofsky's question again is very similar to the previous question. What is the way to write down a report, and which you explained at this moment? There is one more question coming up. The question is, how many capsule readings on an average should be done in order to be able to get used to the lateral view?
It's different from to everyone, yeah. But I think with a number of 10 to 20 cases, you should be totally free of any problems with the software and also with understanding the images. I have some colleagues, they have seen 50 cases and they will never learn it, but they also will never learn it with an EndView system. And I have other colleagues who have, after 5 cases, really a brilliant work. So I would say between 10 and 20 cases, and then you will be perfect with this software and also with this totally new view to the mucosa.
Okay, thank you. There is one more question. How much time should I have to completely read this film? This is from Egypt again, Dr. Walid.
Yeah. It depends on your expertise. How many cases you've seen. This is a totally new kind of view to the mucosa. So you need at the beginning, I will say 20% more time to find in this new viewing mode. But after this, for me now, as you can see here, this case for us. When we look, we have here 5 hours and we're going up. So we have here a passage time from the small bowel about 4.5 hours. I will need for this case 15 minutes, 5 more minutes for reporting. So overall 20 minutes for the total case. Then 12 to 15 minutes for the download. So I will be ready within 30 to 35 minutes, including download, looking at the case and reporting.
Thank you. I think it's 10:30 Eastern time, Dr. Pachofszky, and we are well ahead of the time. So we are coming to the end of the session, and if there is no further questions, there's one more question which has just come up. It is difficult to discriminate between jejunum and ileum as there is no landmark. Do you have any tips for this? Dr. Pachofszky, one question, last question.
It's not easy to say we are still in the jejunum or we are at the beginning of the ileum. Yeah, it's hard to say this. If you have a lot of experience with capsule endoscopy, I think you can do it. It's not exactly, but you can estimate where you are. If you find in the ileum, even in the younger patients, you can see this lymphoid nodules, then you're sure you're in the ileum. Also, I can tell you that the mucosa get flattened when you came to the ileum. You have bigger and longer villi in the jejunum, and the nearer you come to the ileum, they get flattened. Another thing is that you can see more vessels. Maybe we have some luck here in this area. We have those big and longer villi. We can see any vessel. And if you're going down here, maybe here in this area, if you look here at this, you can see some vessels. We are here, I'm sure, in the ileum, and those are so typical things here. You also can see the vessels. Yeah, you won't see this in the jejunum normally. In some cases you will see it, but normally you can say, okay, if I find the first vessels and these lymphoid nodules, I will be near the ileum.
Thank you. So that brings us to the end of this session. I thank Dr. Pachofszky for the time, for the valuable information that he had provided us. And I also thank all the attendees who took time to join this online presentation. We have recorded this event, and this will be sent to you for future reference. I once again thank all of you for your time, and we come to the end of the session. Thank you very much.
Good evening.
Thank you.